Good evening, and welcome back to COVID-19 updates from Singapore. This is episode 29. I'm David Allen, your host of the webinar series, along with my co-host Dale Fisher and Louisa Sun. Thank you for joining us tonight. Hi, Dale. Hi, Louisa. Louisa, tell us how things are different tonight in tonight's episode.
Yeah, good evening, everyone. So we've really had a huge flurry of very good and insightful questions from our audience all around the world since the last webinar. So actually, to kick off today's episode, I shall be spending some time answering these questions.
Great. And Dale, I understand you met someone interesting. Care to share?
Yeah, I'm still reeling over the fact that Louisa's Q&A has knocked me off the feature spot of the show. But anyway, I'll come on later. But yeah, not exactly a well-kept secret. We like to let everyone know that we always have good guests. But yeah, this week we've got Richard Hatchett. He's probably one of the most important people in the world when it comes to ending this pandemic. So be a great interview.
Great. Looking forward to it. As mentioned, we'll open tonight's episode with Louisa addressing questions sent in by our viewers, followed by Dale's epidemiology update. Then Dale will have his discussion with Richard Hatchett, and that'll be followed by the vaccine lightning round by yours truly. Ending this evening, we'll have a reveal of the pandemic song of the month and a video from Dale's secret video vault. Just a reminder, please submit your questions to be addressed in the next month's episode, your suggestions for topics as well, and whether you have videos or pandemic song suggestions you'd like for us to consider. And you'll find the link in your chat box, or you can just reply in the reminder emails you receive between the episodes. So Louisa, let's get us started. What questions were raised by our audience members you'd like to address?
Okay, so there were really a lot of questions. I won't be able to read out all the individual ones, but there are recurrent themes that I will address. So first up, we have Yen Wong from Australia who has asked regarding genome sequencing, specifically to Singapore's technology. So I've received some help from Prof Raymond Lin from our National Public Health Laboratory to answer this. And so our NPHL uses a kit in particular that detects more than 98% of the SARS-CoV-2 genome. But before that, and I've mentioned this before, we actually have a kit that can detect S gene deletions. So to us, this is like a preliminary step whereby we can detect the B117 variant or suspect variants before we go on to do the whole genome sequencing. Now, actually, Singapore's genome sequencing rates and standards is actually quite impressive. According to GISAID, we've actually had the fastest submissions globally in the last 90 days. Other labs locally and in other countries may use other kits that actually generates a preliminary view of the sequence of the genome, before it's complete. And that also allows a presumptive identification of some variants, but a full analysis still needs to be completed before a final conclusion can be drawn. And this leads into the larger topic of the variants of concern that continue to spread and emerge and how this is to be managed. There are also questions about what impacts the variants can cause on different communities, as well as how they can affect vaccine efficacy. So thank you, Judith Varela from Panama, as well as Danilo and Loinda from the Philippines, who have asked questions relating to this. Now, we've always said during the webinar that keeping up with knowledge and developments of the variants is really fundamental, and we're constantly renewing any new data that's emerging. But it's also essential, I think, that we take a rational and scientific approach always to interpreting all this large amount of information that we're getting. We don't dismiss the variants. They are concerning and they require attention, but the message and actions that can be taken are still very clear. And we can't emphasize enough the importance of collective efforts on several fronts that can suppress COVID-19, regardless of which variant. So firstly, it's crucial that we don't loosen or completely stop the existing public health and containment measures that forms the foundation of how many countries have actually managed to achieve and maintain low community rates. So if we're familiar with a certain debate recently that talks about the theatre in a sense, that's really an example of a very undesirable pandemic response. So in any case, we need to keep up with testing and diagnostic strategies as well, which importantly includes increased genome sequencing of the SARS-CoV-2 viral isolates that helps to track their evolvement and geographical spread. And this data has also to be shared and reported in a timely fashion in a common global platform. So it's now clearly also recognized that vaccine development, manufacturing, as well as its successful rollout is also a key to controlling the pandemic. And we need safe and effective vaccines to be distributed widely enough. So all of this needs to be actually accomplished on a global level, and we can't truly achieve control if there are certain communities or regions of the world that are still in disparity. Now, having said this, I just wanted to highlight again that none of these measures or strategies, including vaccinations, are all or nothing on their own. Standalone, even the safest and most efficacious vaccines won't be the single solution that can end the pandemic. And similarly, the variants, although they cause disruptions and also fluctuations in case numbers, as we've seen, don't automatically mean a lengthened path to the end of the pandemic. So even with the variants, we have good and more emerging data to support that the vaccines still significantly lower the chance of severe illness or death from COVID-19. And I think this is actually the most important feature of any good vaccine. So we may accept that mild disease can still go on for some time to come, but more importantly, we want to prevent severe complications and death from infections. So in talking about the role of vaccine strategies, Sundaram from Malaysia has actually asked a very interesting question on how and when we can expect to achieve worldwide herd immunity based on vaccination targets. Now, I think that the main concept to clarify here is that similar to individual pandemic responses, we really shouldn't be regarding herd immunity as binary. So it's more useful to think of it as a concept rather than a fixed number. And the calculation of R0 involves many complex factors, including human behavior. And similarly, there's different degrees of herd immunity that will be considered adequate in different countries and different populations. So as I've just mentioned, we know that vaccines play an important role in preventing serious illness and death. And so that leads to less stress on the healthcare system in general. So we shouldn't be too fixated on achieving a HIT-defined target. I think we should just aim to continue to achieve 100%. And next up, continuing on with the vaccine theme of questions, there are many of you who have actually asked regarding the vaccine eligibility with specific medical conditions, as well as pertaining to our own Singapore's local guidelines. So now do be aware that Singapore's vaccination rollout and guidelines are based on an overall risk stratification on the likelihood of COVID-19 community transmission, which is very low for us, versus a more rigorous safety monitoring and local data review system, and being a bit cautious not to introduce any deleterious events in certain patient populations in the earlier stages. So the overarching message is that for elderly individuals and those with chronic diseases, the risk of severe complications and dying from COVID-19 infections is high. So the vaccination is recommended especially for this group, and vaccination is safe. However, if one particular category of patients we've advised not to be suitable for the mRNA vaccines at this point are those with previous anaphylactic reactions to any trigger or allergen, or very severe allergic reactions to any previous vaccines that they've taken. But we also need to be very clear that anyone with mild allergies, with mild atopy, are actually suitable for vaccination and do not have to be excluded. Now, YC from Singapore asks, what should these individuals who have had severe allergic reactions do if they're unable to take the vaccines for now? So firstly, as our local vaccination rollout is still ramping up, and we're in the process of reviewing large amounts of local data on allergic reactions as well, the guidelines have actually already been updated and will continue to evolve. So we can expect this review to be ongoing, and the recommendations for vaccinations at this point is likely not yet the finalized version. And there's also other vaccine candidates that are being reviewed at the same time. So we know that, with time, there will be options for everyone to get vaccinated. Now, briefly for everyone's information on Singapore guidelines as well, there's currently other groups of patients, such as those with severe immunocompromise, those with chronically low platelet counts, pregnant women, of course, those who are under the known age cutoffs, who we'd advise from deferring the vaccine, taking the vaccination for now, the mRNA vaccines. And with regards to family planning, ACOM from Malaysia has asked about this. Then females should defer their conception until 1 month after receiving the second dose of the vaccination. So, and if you fall pregnant in between doses, then the second dose needs to be delayed for now. And as I mentioned, for those with the chronic stable medical diseases, we encourage you to get vaccinated. But of course, if you have a newly or acutely diagnosed medical condition, especially that of a more severe spectrum, and you're still receiving quite intense treatments or frequent medication titrations, then care can be taken to postpone your vaccination for now until your condition stabilizes. With regards to this, Lisa from Singapore has asked specifically about hyperthyroidism. So I'd say that as long as your condition is stable and your medications are at a stable dose, you are not in thyrotoxicosis, then it's okay to proceed. Vijaya, we don't know where you're from, but you've asked about a very specific scenario whereby a patient has had surgical conditions in both limbs. Now, I'm very sympathetic to this person's situation, but as long as, but these are not contraindications to taking the vaccine. And but just be aware that local site reactions are quite common with the mRNA vaccines. So if you're immediately post-surgery, then I'd wait until the healing process is over before proceeding with the vaccination. Johnny from the Philippines is actually concerned for his grandmother who has angina pectoris. And again, the same advice. If she's had stable heart disease, no recent acute events or heart attack, then it's okay to proceed. If she's recently, unfortunately, had any acute coronary events and is still undergoing any intensive treatments or interventions, then please wait until her condition stabilizes. And the last few questions are to answer on Sinovac, actually, including one from Neo Soon Han from Singapore and Yen from Australia. Now, we know that there are different trials that have been done in different countries and that have reported different efficacies for Sinovac. Now, this is seemingly concerning to a lot of people, but is it really? So Singapore is actually also currently reviewing data on Sinovac, and this is done according to our Health Science Authority, HSA's consistently stringent requirements for reviewing safety and efficacy data of any medications or vaccines. And this is without any outside influence. So for the rest of us, what we know so far is actually from press release data, and we're still waiting for the formal publications. And although the press releases have been done by the study teams, that doesn't equate to us having enough information at this point to really form our final judgment. And one thing to know is that calculating efficacy is actually something that is already highly complex. It's really an interplay between multiple factors. These include participant numbers, populations, the prevalence and rate of transmission of COVID-19, the presence and effectiveness of other public health measures, as well as testing and diagnostic strategies. So we can't really say that the trials that have been done on the reported efficacies can be compared head to head. Just the trial participants alone have been very different. Indonesia's only recruited the general public, Brazil's only recruited healthcare workers, and Turkey's actually recruited a mix of both. And there's very different trial participant numbers in each of these. So, and it's not hard to realize that these trials would have been done under very different pandemic situations, especially in Brazil. We know that they would have been having a very rampant COVID outbreak at that moment. So it's very likely to have a significant effect on how we determine vaccine efficacy as well. So we'll still need to wait for official data from the publications when they're released to be able to draw further conclusions. But putting aside all of this, I think we also need to go back and just review what are the fundamental qualities that define a good vaccine. So we were really blown away by the super high efficacies of the mRNA vaccines, which unfortunately also set the bar a bit unfairly high for the other vaccine candidates. Comparing vaccines is very different also from comparing different trials. So we're not using these mRNA vaccine efficacies as the gold standard for other vaccinations. So a successful vaccine is actually one that is safe as well as can achieve an efficacy of over 50%. So what I can say from what we know for Sinovac so far is that it's another safe vaccine candidate that works. So this is the end of the Q&A section. I know that there's many of you who haven't had your names mentioned so far, and apologies we're not able to give you an individual shout out, but I assure you that your questions are actually going to be answered by Prof David and Prof Dale in their segments. So, and with that, I'd like to welcome Prof Dale to give his updates on EPI.
Thanks, Louisa. I think everyone can now understand why we've created a segment called Q&A. It really doesn't do them justice just to try and manage them during the show. So let me swing over to the EPI now. This is where we're at, and of interest is the ones up the top here with Brazil really firming as a major issue, and I'll come back to this a bit later. United States, interestingly, has come down to third in the most cases over the last 24 hours, and deaths are right down in those countries as well. So that's the highest level view, and of course, looking at each of the 6 regions of the WHO, you can see that generally the news is a bit disappointing at this sort of high level. The Americas are creeping up in terms of cases and flattening in deaths. Europe, you can see, and I think everyone will be aware of this, the case numbers are really hiking. Also in Southeast Asia, largely driven by India. Eastern Mediterranean also going up. Africa holding its own over the last few months, and WIPRO, the Western Pacific region, our region, case numbers surging there. So let me tease that out a little bit. I haven't shown the Johns Hopkins dashboard for a while, but I wanted to this time just to highlight these 3 countries here, which are the highest death rates, all neighbours. So I think that was kind of striking to me this time round, with the other countries dropping out. So let's talk about the Americas. They generally have about 30% of the global cases and deaths, and you can see what Brazil's doing here. Let's dig into this a little bit more. You can see, firstly, you can see a fair bit of red. And as I say, so red really mean, or this colour, pink if you like, is between 10 and 50% increase, and red is more than 50% increase. So many countries like this are going the wrong direction, which is disappointing. More than a year into the pandemic, and Brazil, as I say, is looking like a new epicenter. Let me just take you to Brazil now, and this is their epi curve since the start of the pandemic, and now it's really like each day it's setting a new record. There's so many things going wrong in the Brazilian response. We know well about the poor leadership and coordination and conflict between leaders within the country. But now we're looking at overwhelmed hospitals, overwhelmed intensive cares. Many areas are running out of oxygen or have run out of oxygen. Their testing, I was reading, is largely based on antibodies, which is crazy. I know MSF are in there trying to do more work, scaling up PCR and rapid antigen tests, but actually you can see from these numbers that it's probably not about right if you're having 2,000 deaths a day, then to have just 50 or 60,000 cases, the ratio is not quite right, and you can see that much more clearly in the US, where you've got 50 or 60,000 cases a day, and also the 2,000 deaths a day. So Brazil's also got this slow vaccine rollout. Slow vaccine rollout. It's actually exactly the type of country we should be supporting in their rollout. We all talk about the COVAX facility and how we've got to look after these low and middle income countries. But in Brazil, only 6.2% of the countries had 1 jab, and 2.1% of the country have had 2 jabs using Sinovac and AstraZeneca. But both of those have had the value questioned against the P1 variant in Brazil. So this is of concern when really you see other countries well into double digits, and this country, which is actually home to arguably the most worrying variant in the world, is allowed to replicate so freely. Manaus also showed that actually that variant is escaping pre-existing immunity from past exposure. We discussed Manaus, I think, 2 months ago, and They've done whole genome sequencing on those, and about 91% are the P1 variants. So that kind of explains or supports the theory as to why that happened. What else has happened? That's about all. The whole genome sequencing isn't really adequate. Brazil's sequencing about 3,000, 1 in 3,000 of its positive PCRs, whereas US, which is actually criticised for not doing enough, is doing about 1 in 200 confirmed cases. So I got this wrong before. It's between 200,000 and 300,000 cases per day here, and you can see at their peak they were like 4,000. So this is like tenfold underestimating it possibly. So let's go to Europe. This has got the most cases recorded, 41% of global cases, 50% of almost of global deaths. We dig into that a little bit, and as we all know, there's plenty of red happening. France has got new highs with or new highs for this year with around, and they've got around 4,000 cases in ICUs. All these countries are scaling up or most of them are scaling up their restrictions. Poland's under a partial lockdown. Italy are planning a national lockdown over Easter. And you recall, we have a lot of outbreaks related to religious festivals and religious events. So there is a bit of consternation about what could happen in Easter. Ukraine as well, they've got various permutations, not of no in-restaurant dining, closing schools, this type of thing. Netherlands, as well as Germany, have both announced an extension of their tough restrictions. In fact, in the Netherlands, bars and restaurants have been closed since mid-October, I understand. Germany, there was a little faux pas there. They wanted to announce a lockdown during Easter, but Angela Merkel's had to retract that, and it's turned into more of a request. UK is interesting. That's one of the successes here. They've brought in a lot of border restrictions. There's a new law about you're not allowed to travel out of the UK unless there's a good reason. So I'm not sure of how that's going to be implemented. But there's a lot of countries that they've red listed, which means they're not allowed to enter the UK at all unless they're a returning resident. And if they're a returning resident of the UK, they'll have to pay quarantine. So in terms of other things, Czechia is one of the blue ones, but really you look at the number of cases per million population and it's very high. So it's only coming down because I think it was last month it was really one of the worst, and actually it's coming down, but actually got amongst the highest numbers here, both in terms of cases and in terms of death rate. So just to talk about the UK and Belgium, they're also, sorry, not the UK and Spain, actually they've come down quite nicely. I'll talk about the UK a little bit more, but you can see with largely restrictions, but also vaccine, that they've got their numbers quite nicely down into triple figures, and also death rates are down into single digits per million population. So those two countries are possibly the outliers here. Greece has got an interesting little plan. They're giving out test kits to people. They're giving them a quota of 4 per month, and they want people to do these rapid test kits. And if they're positive, then take the necessary action. So that's a fairly novel approach. We can be cynical about it, but let's see how it happens. But again, mostly you can see that these are still largely red. Big outlier here in Israel. So the case numbers down significantly, deaths down significantly. So that brings me to this slide, which I've made up, which really describes Israel and UK, because they are the two outliers in this part of the world. Israel, where there's 57% are vaccinated, you can see at this peak here, they were about 8,300 cases per day, the 7-day rolling average. They're now down to 800, so it's 10% of what it was. And likewise, the deaths have gone from 65 down to 14. The UK, about 43% are vaccinated. And again, you can see what's happened here. I'm not saying it's all about vaccine, because there's a lot of restrictions, at least obviously in UK, but nonetheless, this 60,000 people a day peak has come down to 5,400 now, and deaths have come from what was about 1,200 down to about 80. So I think this is what Louisa was talking about with this emerging herd immunity, if you like. It's not binary. You don't have to reach full herd immunity before you start seeing an effect of the vaccines. Here we've had a regional tick up with numbers really not seen in the sort of South Asia region. We haven't seen these since November, and it's largely due, not that the numbers are huge compared to the others per million, because these are big countries, but you can see it's very, very red. India is, it's a year since it had its big national lockdown starting March 24th that they had for 3 months, and this tick up now is blamed on less mask wearing and social distancing and all the usual things that make the numbers tick up. India is actually a big maker and exporter of vaccines, and there's criticism why this is being allowed to happen with 3.2% of the population that have had 1 jab and only 0.6% of the population's had 2 jabs. Still a lot of jabs in 1.3 billion people, but nonetheless, it's there's criticism that they're giving a lot of vaccine away. The Serum Institute of India is the world's biggest manufacturer, and I think India overall makes about 60% of the world's vaccines. So where's it happening in India? It's happening in these 5 provinces, particularly Maharashtra here, and these 5 provinces account for 77% of all the cases, and all these in India, and all these are occurring on the increase now, and there's varying responses, including various full and partial lockdowns, shutting schools, curfews. They've identified a new variant. They're calling it the double mutant, which sounds a lot worse than a single mutant. I haven't really read what it means. I think it's a combination of 2 variants that they've already recognised that are sort of looking like they've combined into one. So that's kind of where we are with this new mutant. I think we're going to hear a lot more about whether it's more transmissible or virulent, just like all the others. But that always takes a few weeks or a month or 2 to really tease that out. As I say, it's a stretch to blame a new mutant or anything on this. It's they had. It's in Maharashtra, out of 200 samples that had whole genome sequence, 20% of them were, of all these samples done here, 200 were found to be this new variant, and 20% of the ones in Nagpur, which is in this province, in this state, were found to be this variant. So we can just have a look here. There's sort of record numbers happening in Iraq and Jordan. We can just drill down a little bit here. Iraq had its highest number of cases, 6,000 yesterday in a day. Perhaps the biggest outlier here again is UAE. You can see that their numbers are going down compared to so many other red ones, and the death rate is markedly down. And as we know, they've been vaccinating very aggressively. UAE's got 73% of its elderly vaccinated, and 56% of all adults are vaccinated in what is a population of 9 million. So it's again, I guess some real world information. The African region is chugging along as it has with reasonable control, smallish numbers of cases and deaths for the large continent. Western Pacific region, again, look at this big spike in the Philippines. That's what's driving the numbers a little bit. If we, again, drill down, we've got this Philippines surge here, up 54% in the preceding week. Interestingly, we've got a nice and timely, I must say, fall in Japan as they're sort of making announcements about the Olympics, which start on July 24th. The relay began today, and the announcement that there'll be no overseas fans allowed at the Olympics. Let's look at a couple of these countries. We've been tracking Hong Kong. This last little blip here was a gym cluster. So these are the Hong Kong's clearly got it under control. Only 10 cases yesterday, and at most 0, 1 or 2 deaths a day. Philippines, most of these are happening in metropolitan Manila and the surrounding provinces. And again, they're scaling up all their interventions, including curfews, mass gatherings, maximum of 10 now. People between 18 and 65 aren't allowed outdoors. There's a thing. And they're also upping border restrictions. It's now closed to foreigners. Okay, let's just have a quick look at these. Cambodia, you can see, is they've had a couple more deaths, so they're up to 7 now. It's a crisis compared to other countries. It's quite incredible. These cases are actually existing in 4 or 5 clusters, which they're still working to shut down. Vietnam is down to 1 case yesterday. You remember they had some imported cases that caused some local spread, but really they haven't had a death since September. Thailand, likewise, the influx of cases from Myanmar workers coming over the border caused some outbreaks in their migrant worker groups. But again, done well to bring that under control. And Malaysia, likewise, they had a bigger problem, but they're generally bringing things down. The cases peaked at 4,700 here, now down to about 1,300, and the deaths were 16 a day. Now they're down to 4. I had a question from Nitin Bandari in Nepal, who asked about the most successful low and middle income countries. And he asked about the public health interventions and also the vaccine rollout. So let me tell you, the vaccine rollout, all these countries have a problem because they're very reliant on gifts and COVAX and places like that. So I think they're very able to vaccinate, but they've got a problem with supply. The most successful country I could find was Maldives with 23% vaccination rate. So it's obviously a small country, and all that was AstraZeneca provided by the Serum Institute of India as a gift, some vaccine diplomacy going on there. So, but really they're very dependent on getting walked over somewhat by the bigger economic countries. In terms of the public health interventions, most of these countries have survived so well by sort of rigorous border closures like Fiji, Vanuatu, Tonga, but they've also suffered heavily economically with those border closures. I like the way these countries have done. They've been tested, they've responded well, and this is all public health interventions. Obviously, these aren't well vaccinated countries. So I think here's some good examples of how they've done it. How have they done it? They've done it just by doing it, by engaging the community, by doing the contact tracing, by isolating positive cases, quarantining contacts. They've just done it the right way rather than relying heavily or solely, for instance, on borders. Okay, Singapore, we can do this very quickly. There's just zeros everywhere here. There's a couple of cases in the community 2 weeks ago. But really all the numbers are coming from imported cases, which have snuck up a little bit again recently, but these are all diagnosed in quarantine. So very simple. And again, this is exhibited here with the imported cases representing all our cases, a handful in the community and none in the dormitories. We've had 1 death since last time on March the 12th, otherwise none in ICU, handful in the general wards, some in care facilities, but we're in pretty good shape in Singapore. David, sorry.
Hey,
I took up the whole show.
That was all right. There was a lot to be said. So thanks. Let's just turn the ride around back to you. You're going to introduce us to a nice gentleman.
Yes. Let me tell you, Richard Hatchett is the CEO of CEPI. Now CEPI is the Coalition for Epidemic Preparedness Innovations. They've played a key role in COVAX. They're one of the co-leads of the COVAX facility. I had to interview him last night because he's a busy man, but I started off by asking him how CEPI actually started.
CEPI is a new organization. It was established only in January of 2017. It was really the response to the global experience with the Ebola epidemic in 2014 and in 2015. And in particular, it grew out of the recognition, the sort of tragic awareness that a vaccine, the Merck, what's now the Merck VSV vaccine, that was ultimately deployed at the end of the Ebola epidemic, that it had been under development for more than a decade, and had not been advanced sufficiently to be able to deploy rapidly during the epidemic. Of course, it ultimately was accelerated through the early phases of clinical development and then deployed into the ring vaccination trial and shown to be 100% effective. But it came so late that it really had no impact on the epidemic itself. So CEPI was set up with the idea, after a lot of after-action reports, was set up with the idea that it would focus on the development of vaccines against emerging infectious diseases, focus on the development of rapid response platforms so that the world could respond rapidly to new threats, and focus on ensuring equitable access to those vaccines for the populations that needed them. So, of course, we do work very closely with our partners, WHO and Gavi. They're our core partners in COVAX, of course, but we worked with them closely prior to the emergence of COVID-19, and we built on the foundation of our relationships in conceptualizing and setting up COVAX.
Okay, I didn't know that. So this is really a good outcome of all the high-level reviews that happened after the Ebola in West Africa. Interesting. So Richard, can you take us through 2020? When did you really get mobilized? I suspect it was before anyone was even thinking about it. You were already starting your work, or did you need the fake, or what was the trigger for you to start work?
Well, we actually in 2019 had been developing our emergency response protocols and thinking about different postures of alertness that we would take in the event that new diseases emerged. We had to respond in 2018 and 2019 to the Ebola epidemic in DRC, and we helped stand up clinical trials in Goma, which was a tremendous challenge in its own right. But we were very aware, even before COVID, that we needed to be ready to respond. So when the first alerts were issued in the very end of December 2019, in the first days of January, as we were all coming back from our holidays, we actually elevated our alert posture. And so we were tracking the news that was trickling out of Wuhan. Between January 15th and January 20th, I don't know if you remember this, there was a period when the cases in Wuhan seemed to be just stable. The numbers were not changing very dramatically day to day. And then between January 15th and January 20th, they escalated, I think, from around 40 or 50 cases up to several hundred.
Yeah.
And the sequences had been released on January 12th, revealing that this was a coronavirus, which we had been concerned about as a potential pandemic threat. I mean, in fact, we can talk about our prior investments with MERS and the rationale for those investments. But by January 20th, we realized that, and given that there were now hundreds of cases, and it was evident, although nobody was saying it, that person-to-person transmission was occurring, and that it was clearly easily transmissible given the number of cases that were being reported. So our concern at that point was extremely high. And we actually issued our first contracts for vaccine development on January 23rd, when there were fewer than 1,000 cases. So we jumped in very early. We recognized very early on that we were facing a likely pandemic threat. We didn't know, whether the actions in China would be sufficient to contain the virus. We were concerned certainly that they would not. And the early months of the pandemic for us were a period when we focused on what I retrospectively have referred to as kind of the ignition period, which was get money out the door as quickly as possible, find partners that had plausible vaccine candidates, and get them funds to get their efforts started as quickly as possible. And during that period, we funded partners like Moderna, like at the time it was University of Oxford. This was before AstraZeneca became involved, CureVac, Clover, the University of Queensland, and a number of other partners. By March, our portfolio, which ultimately initially grew to include 9 investments, and those were globally distributed investments, had been established, and the vaccine development efforts were underway, and our attention shifted actually to thinking about how to ensure access. I had served as a member of the National Security Council in the White House in 2009 during the last pandemic, and it lived through, in fact, it had led efforts to develop policies around vaccine donation and anticipated the pressures that governments would be under to serve their own populations, and anticipated that what we saw in 2009, which was a handful of countries essentially cornering the market on vaccines, would be replicated in 2020 unless we did something to prevent that from happening. And Seth Berkley, the CEO at Gavi, and I, even we both attended Davos in January. Even at Davos, we were talking about the need to develop mechanisms to ensure equitable access. And starting in March, we began to really think through how that could be, actually implemented. And so we working closely with Gavi, conceptualized the idea of COVAX, which was a global mechanism to provide equitable access. And most of 2020, we were preoccupied with standing COVAX up, getting funding, securing buy-in from countries. Of course, Singapore was a huge champion. Prime Minister Lee was a huge champion for vaccine multilateralism, and actually Singapore chaired a group of like-minded countries that called themselves the Friends of the Facility and helped us with some of the early startup. Later in the year, our attention began to shift again. So after COVAX was up, and as it began to shift from sort of a design phase and a focus on the R&D and actually bringing the vaccines along, to thinking about how it would actually procure and deliver those vaccines, CEPI, in our role as an R&D funder, we began to think about, do we have the vaccines that we need to manage COVID for the long term? Because we anticipate that the disease will become endemic and it will be part of the viral landscape for the foreseeable future. So we began to think about second generation vaccines. And while we were doing that, the variants began to emerge. And that increased the urgency of some of our R&D needs. We have now, while we're continuing to think about second generation vaccines for COVID, while we're thinking about how to respond effectively to the variants, we are also turning our eyes towards the future and thinking about the post-pandemic future and what the world will need to address epidemic and pandemic threats more broadly.
So there's a couple of things there to just unpack. The variants. So are we already tweaking the first generation of vaccines that came out?
We are. In fact, we're seeing the companies like Pfizer, like Moderna, the group at Oxford, and others, immediately jumping on to the problem of the variants. And as you know, we're beginning to get some data with some of the vaccines that fortuitously were being tested in locations like Brazil or like South Africa, where the variants emerged, or even in the UK, beginning to get some data about the current vaccines. And we've got, as I said, a number of partners, already proceeding to develop variant-specific vaccines. And some of the most recent work that CEPI has funded with SK Biosciences, with VBI, these are some new vaccine projects we've recently announced, are actually also specifically focused on developing variant-specific vaccines.
And you've mentioned COVAX a lot. Are you happy with the way that's rolled out?
I look at COVAX as an improvable model. COVAX faces tremendous challenges. It has rolled out slower than any of us would have liked, but I think it's important to realize that COVAX had to be conceptualized, stood up, designed, funded, and secured buy-in in the midst of a pandemic. And so I think, we're proud of what has been accomplished. There are mistakes that we've made. I think, there are places in retrospect where we could have made different choices, and maybe things could have been accelerated a little bit. But I think it's really important also in assessing the performance of COVAX, in placing it in context. And the context is, what is the history of life-saving medical interventions, being shared with the entire world? If you look at highly active antiretroviral therapy, there was at least a decade between, those drugs for HIV becoming available in high-income countries and becoming, widely available in Africa and elsewhere. That was a decade of extra mortality in Africa. If you look at 2009, there was a vaccine donation program in 2009 led by the US and 8 other countries, Sanofi, GSK. In a year, that program rolled out, I believe, 78 million doses of vaccine to 77 countries. COVAX, in its first 3 weeks of rolling out vaccine, rolled out, over 30 million doses to somewhere just north of 50 countries. And of course, those numbers are going to continue to increase. And our aspiration for, the first year after vaccine becomes available is hopefully to deliver up to 2 billion doses.
Is the choke point in actually getting the vaccine?
It is. But there are multiple things that you have to work through. The bottleneck in vaccine supply, the scarcity of vaccine supply, is a major issue right now. That will gradually improve. We've got at least 9 manufacturers currently that are massively scaling up their production, and those vaccines will become available over time. There are some, we are committed to delivering vaccines that have gone through stringent regulatory processes and have gone through the pre-qualification process at WHO, and that takes time.
I guess in a way it's good that you've got that sort of lead time to get the clunks out of the COVAX mechanism, and then by the time you've got the vaccine, it'll presumably be very, very smooth.
We're hoping it will smooth out. When I talked about it as an improvable model, I think it also advances the yardstick on issues of vaccine equity and what the world will accept. And I hope that COVAX, is looked at as we emerge from the pandemic. I hope that COVAX is looked at as a valuable piece of the international architecture that needs to be, funded so that it can move quickly, or something like COVAX can move quickly in the future, and that we can fix the things that haven't worked perfectly, as we were working it out in real.
What's your sort of rights over the intellectual property? You've a lot of this happened because of CEPI. Certainly got a lot of funding from CEPI, but have you got rights as to who should get it and this sort of thing?
Well, so when we make partnerships with companies, particularly when we make the very large investments that we made with certain companies like AstraZeneca and Novavax, we secure equitable access agreements. And what those equitable access agreements have meant in this context was that what became the COVAX facility, in fact, we established the agreements before the facility even existed, but essentially the facility has a a first right of refusal to doses that are created because of the CEPI investments. And so where we invest in expanding manufacturing capacity, doses coming out of that capacity, COVAX has a first right of refusal. We don't seek to have ownership over the intellectual property of the vaccines that we support per se. There have been lots of debates about how do we expand manufacturing capacity and lots of discussions about the important role of intellectual property in that. I don't see intellectual property as being the main bottleneck to the expansion of capacity because of the unique nature of biological manufacturing and the challenges of transferring, production from one facility to another. I think they're among the rate limiters are limitations of staff with the requisite technical expertise.
Yeah.
There's a lot of know-how that has to be transferred, and it just takes time to set those processes up. A few manufacturers have succeeded in doing tech transfer in 6 months, and that's light speed under any normal circumstance.
You're arguably one of the most key individuals in ending this pandemic. So I don't know what the dinner table conversations are like, but can you tell me what keeps you awake at night?
One of the things that keeps me awake at night is staring at a computer screen till 1 a.m. That's terrible for sleep hygiene, but I don't think that's what you were asking.
We're all used to that.
The thing that keeps me awake at night, there are two things. Sort of a near-term problem is, we have to reduce the equity gap because really if we don't share vaccine globally, we're not going to bring the pandemic to an end, and you can't end the pandemic by ending it in one country or another country just by protecting the population. And so the inequitable distribution of vaccine is going to prolong the pandemic, and that means more deaths, it means more economic disruption, and it means a longer pandemic. And that's what we're struggling in the near term to overcome. In the long term, the thing that frightens me, I wouldn't say it keeps me up at night, but that frightens me is that COVID is far from the worst case, imaginable. COVID has cousins in SARS and MERS, which had mortality rates of 10% and 35%, respectively. We know there are at least 100 other coronaviruses that have already been identified through bioprospecting that are out there. Coronaviruses, if you had a coronavirus that combined COVID's transmissibility and anything like the lethality of SARS or MERS, that would make what we've been through look like child's play. And there are probably, some have estimated, well over 1 million viruses out in, mammalian hosts that are just waiting for an opportunity to cross the viral frontier and enter into human transmission. And so that's what really keeps me concerned. It actually has led us in terms of our thinking about, responding to future pandemics. We've just laid out our 5-year strategy for what we're calling CEPI 2.0. And that's really built around how do we respond to threats that we know about? How do we take COVID and other coronaviruses off the table as threats? And how do we prepare for the threats of the future?
Actually, that was going to be my last question. Did you just want to elaborate on what the strategy is so that we can be better prepared for the next pandemic?
Sure. Well, it clearly builds on lessons that we've learned from this pandemic, and it will also build on the technologies that emerge from this pandemic and that really position us to respond much more rapidly in the future. My ballpark estimate is that we've compressed about a decade of technology development into a year, and we will emerge from the pandemic with 3 or 4 or 5 new vaccine platforms that have been validated for the first time in the context of the pandemic. In 2020, we delivered a licensed vaccine or an approved vaccine, time from release of sequence to approval in the UK for the Pfizer vaccine was 326 days. A central pillar of what we're arguing for is that we, the world, collectively, and CEPI's got a part to play, but we, the world, collectively, need to reduce that time down to about 100 days. we also need to be ready to respond to any future threat, wherever it comes from. And there are 25 or 26 viral families that are known to be able to cause human disease at least as quickly as we responded to COVID. And there's a wonderful anecdote about COVID, which if you have just a minute or two more, I'd like to tell, because I think it points to the future, which is that, the Vaccine Research Center at the National Institute for Allergy and Infectious Diseases in the U.S. had been working for a couple of years on MERS as what they called a prototype pathogen. And they had, identified obviously the spike protein as the main immunogen, and they had engaged in introducing mutations that stabilized the spike protein and optimized its presentation to the immune system in a way that increased the potency of the immune response. Within 24 hours of the release of the viral sequences, the Vaccine Research Center had designed the Moderna vaccine, what became the Moderna and Pfizer vaccines. So within 24 hours of the sequences being released, they had designed vaccines that were shown to be 94, 95% effective. And the rest of the year was just, demonstrating that to the, until the regulators were happy. So we need to be able to do that for all 25 or 26 viral families that we know present threats, and be able to respond as rapidly as we did for COVID with any potential threat. And that's a key pillar of what we're hoping to do over the next 5 years.
Look, Richard, that was absolutely fascinating. Everyone that tunes into this webinar very loyally will be so grateful to have heard from you. Thanks for everything you've done during the pandemic and before and afterwards. It's been a pleasure. Can't thank you enough. Thanks.
Great. Thank you, Dave. Thanks for having me.
All right, Dale. That was a very important message to hear. The cool, calm, professional, strategic approach to dealing with this by an entity that really doesn't get a lot of airtime and doesn't want the airtime, is going about their business, anticipating this pandemic and preparing for the next one. So that should give us some reassurance. We are going to go late this evening. Our apologies in advance. So let's just jump right in. This is the monthly update of what's going on. There's actually 13 different vaccines out there that have been approved. Novavax is not being counted amongst them, as no one has approved it just yet. And you can see that there's been a big surge in the number of countries that are utilizing Gamaleya, which is the Sputnik 5, and with the J&J as it became approved in the United States, and other countries have taken it on, as well as the WHO. Once WHO has approved for emergency utilization, then COVAX can distribute it, of which, as Richard mentioned, they've distributed 30 million doses to about 50 countries now. This is slightly behind. You can see in ASEAN, some vaccines, such as the AstraZeneca, have been emergency utilization in 6 countries. Others have had fewer. You can see that the ones that have the most distribution are Sinovac, AstraZeneca, and Gamaleya. Oop, there we go. And just a little update about the vaccine doses. You can see that 486 million have been distributed as of today, or given as of today, and that's an increase of 260 or 270 million from a month ago when we last met. Israel, percentage of population-wise who've been fully vaccinated, leads the pack as far as percentage of the population that's received one vaccine. Seychelles is ahead at 66, and you can see in Singapore we've really been moving quite quickly and are now able to vaccinate 40,000 people a day. In our part of the world, you can see the number of the percent of fully vaccinated, 5% locally, and less so in neighboring countries. I put this slide up. It's an interesting slide just to be a little bit of a contrarian. You can see the number of vaccine doses given per 100 people daily. The red line is Israel. The black line is United Kingdom, and you can see the number of new confirmed cases per day. What I want to show you is in Israel, they've vaccinated 51% of the population, meaning they got 48.8% left to go, yet the number that are being vaccinated daily have fallen off. Now, that could be for a variety of reasons. It could be because of supply. It could be because they recently had an election. It could be for holidays. It could be for hesitancy. I don't know. And we wouldn't expect to see this leveling off at this point in any event, the number of new cases. But it'll be interesting to monitor because United Kingdom is ramping up the number of cases, and obviously they've continued to slide down. Just something to note. Locally, the countries that have begun vaccinations, actually, this is what up here on the right-hand corner is from, let's see if I can get a pointer. Cannot, okay. That was on the 25th of February. All these countries either hadn't started, there's no data. But as of today, these are the only two countries in the region that haven't begun. But in fact, Papua New Guinea has received doses from Australia and will begin this weekend. Timor-Leste is in COVAX and is expecting some supplies to be delivered. So let's jump into the lightning round. Who's eligible? I think all of us know this from reading the paper. This is updated in the last couple of days. It's 45 years old and older. You can see these other criteria. The drivers is delivering goods from Malaysia. The migrant workers that haven't been previously infected, up to 10,000 of them, essential workers, teachers, and an area that is being explored and looked into is the logistics for vaccinating the homebound. It's not terribly easy to do because of the ultra cold requirements and needing to observe people in their, for a period of time after vaccination, but that is being pursued to put that into place for those who are homebound. So let's just chat about vaccine diplomacy. It was spoken to by Richard, alluded to, and the givens are that we're either all protected or all at risk, and as long as the virus is spreading, variants will evolve. And countries make decisions. They make decisions how to most efficiently protect their citizens by vaccinating their citizens, but also by providing vaccine to other countries that directly or indirectly protects their own citizens. Obviously with the lorry drivers from Malaysia, that's prudent for us to vaccinate them. Singapore is involved in COVAX, as mentioned by Richard very early on. And additionally, there are many other programs involved in, but there's an ASEAN COVID-19 response fund. That's in response to a question that Danilo Animus from the Philippines had asked about what's being done. But the timing of sharing of very precious vaccine is a delicate issue. As Dale mentioned in the epidemiology update, India is sharing vaccine, yet they've only vaccinated a small portion of the population. This is a very challenging thing. We understand that we need to get everyone in the world vaccinated, but our population who is our primary interest wants to make sure that they get theirs as well. So it's a tough tightrope to walk. And how most effectively to help this world? Well, there's certainly through altruism. That's an important motivation, but there's self-protection, as I mentioned here, because it directly or indirectly protects us. But there's also the notion of influence, and the world powers are definitely doing that. And you'll see that in just a moment by where vaccine is being deployed. I'm not saying that's a bad thing. I'm just saying it is a reality. So why does vaccine inequity matter? We hear a lot about it, and you can see high income countries have already started 90+%, upper middle income, lower middle income, and low income fall off precipitously. Now this is improved since this chart was made in March 4th, but it's still, there is inequity. And the reason it matters is because there's risks of prolonging the pandemic. There's more infections and deaths and more variant evolution. There's more long COVID, which occurs up to 30% of the population that gets infected. The concerns about economic fallout. And also, if a country is unable to get vaccine that is approved, then they may, in desperation, use unproven vaccine, which creates problems when how do we know that their population's been adequately vaccinated when we attempt to open up commerce and tourism, et cetera. There's also concerns about discrimination. I didn't get vaccinated, I can't get a job. And all of this leads to increasing vaccine hesitancy, which then feeds the loop. So vaccine inequity matters a lot. And these are the different vaccines right here. In the left upper corner, I have the Pfizer-BioNTech, and you can see that it's primarily in North America and Europe, and a little bit in South America and Australia. And AstraZeneca out of the UK, it's mostly in Europe and a little in South America. Sinovac is in China, Southeast Asia, South America. And Sputnik 5, which is out of Russia, in Russia, Turkey, South America. You can see Africa is lost out on many of these. However, through COVAX and a variety of the things in the 2 weeks or 3 weeks that passed in between these drawings, that they're starting to get more distribution into Africa. So let's just chat about AstraZeneca. It's gotten a lot of public relations, not all of it welcome here in the last, since the beginning of the year. Past issues and ongoing issues, including manufacturing shortfalls. They're still not delivering on their contracts, which has led to quite a bit of consternation, and remediation for that is in progress. The EU is concerned that the AstraZeneca was sending vaccine elsewhere before fulfilling its contracts. That's still being discussed quite in the press as well as behind closed doors. There were early on concerns about those greater than 65. There wasn't efficacy data that has come out, so that seems to be resolved. And the low dose, high dose part of the vaccine that showed a higher efficacy at 90% may actually have been resolved because there was actually longer intervals between doses, and we've subsequently learned that that longer interval for AstraZeneca up to 12 weeks actually improves its efficacy. As far as current issues, I've mentioned the geopolitics and manufacturing shortfall, which is still going on. Efficacy issues versus variants, such as the South African variant B.1.351. So they're going to address that, and I'll speak to that in just a moment, with booster and updated vaccine that takes into consideration B.1.351. And then last week, or a couple of 10 days, we had issues with clotting, and I'll show that on the next slide. And then in the last 2 or 3 days, we've had issues with releasing results from the US, Peru, and Chile trial, which they had a public rebuke from the Data Safety Monitoring Board. They initially reported 79% efficacy. There was concerns they were utilizing old data and not giving complete information. Subsequently, they updated that, and it's 76% efficacy. It sounds like a piddling amount, but it's a public relations problem. Sadly, all of these things have distracted from the reality that AstraZeneca, the vaccine ChAdOx1, is actually a very excellent vaccine. They've just not managed it well. I'm not going to go through this in great detail, the coagulopathy, but the long and short of it is the DVT and PE, pulmonary embolus concerns. It's really, when compared to what the background rate, it is either at or below the background rate. The bigger concern was the cerebral sinus vein thrombosis with thrombocytopenia. There's been 18 cases and 20 million doses recipients. So that's a rate of, you can look at this, a very small number, much less than 1,000%. But the cases, strangely enough, all occurred in Europe. They were from the manufacturing plant, which is in Europe. They also have plants in India, soon to open in Australia. They have it in South Korea and Japan as well. And when they looked at the data, the European Medicines Association Authority found no vaccine association with thrombosis, but it didn't rule out the possibility of the cerebral sinus vein thrombosis. WHO says essentially the same thing, that the benefit of the vaccine far, far outweighs the possible risk. And when you put it in perspective, it really does. This is an extraordinarily small number where this is being observed, and yet COVID, the disease itself is associated with a stroke incidence of 1.7%, a fatality rate of 2.21%, with a mortality of 0.1%, and an estimated death of 2 to 3 deaths per million per week in those in their 50s when the vaccine program is delayed. So the benefit of the vaccine many hundreds of times over, thousands of times over, is more beneficial to give than to not. But the fallout from this is been vaccination delay, some loss of confidence, trust, and hesitancy. The way to deal with this is going to be just engagement, communication, transparency, etc. Things that have been done but just need to be continued. So it brings up the issue of hesitancy, and one of the questions brought up was, is there more reassuring ways to answer the concerns of vaccine hesitancy? And the reality is, there's not one single cause of vaccine hesitancy. You can see all of these between the logistics and the different issues, the personal issues with the AstraZeneca, the concerns about the risk-benefit, which I hope I've convinced you it's overwhelmingly beneficial, and then the societal determinants of hesitancy. So it's not a simple answer. So let's just briefly run through some of the variants without a lot of detail being spent, time being spent on the details. I'm just going to show you that due to the mRNA vaccines, this is the Pfizer and the Moderna vaccines. Great, this is neutralizing antibody. The higher the neutralizing antibody, the better. You can see to the wild type, the UK variant and the Brazilian variant, if these are absolute measures of it, or median measures, they all stay pretty high. But against the South African variant, the B1351, it drops down. That's concerning. This is demonstrated in a very nice cartoon here that shows the wild type. This was the variant that replaced the wild type in the middle of last year and has been the dominant wild type strain at this point, effectively the wild type. This is the UK variant. This was the Denmark or the mink variant. What's going on in California? This is the Japanese Brazil one, the Brazil P1, and the South African. You can see as you move across these variants that the level of neutralizing antibody that's engendered or created by the current vaccines, 2 doses, drops off. So the notable updates, this is a slide that I've shown the last couple of months. The notable new information is we have a little more information about the South African strain as far as what Novavax has been able to do. It's about 55% efficacy. The sad one is the AstraZeneca, because against the strains specifically that are South African, it's been less than ideal. But the good news is those who have actually had the South African infection itself, not the vaccine, toward the South African variant, but actually had infection with it, they developed great neutralizing or good neutralizing antibody levels against the original SARS, the wild type, as well as the P1 variant and probably the UK variant. So the prospects for the B2, the version 2 of this vaccine, of all vaccines, is going to be actually quite good. And as Richard mentioned in his segment, all the manufacturers are working on those versions. Also, that the mRNA vaccines, the Pfizer, the Moderna, was found to induce T cells, even if their neutralizing antibody levels were low. In some patients, they developed wonderful T cell activity against all variants, despite low neutralizing antibodies. So that's somewhat reassuring that there's more to protection than just neutralizing antibodies, which we knew already. So this was in response to a couple of questions about what happens after one vaccine, because some countries, based on modeling, are getting it out to as many people as possible, 1 dose, and after they catch up, they'll get 2 doses. And the reality is that you do get, there is efficacy. You can see for Pfizer-BioNTech, around 90%. Moderna is expected to be about the same. AstraZeneca, J&J, which is a 1-dose vaccine anyway, and these we don't know anything about. The problem is how long or how high the peak neutralizing antibody is after 1 dose, and the duration of measurable antibody may be shorter compared to receiving 2 doses. The duration of protection may be shorter, and there's concern about, because you only have a modest level of neutralizing antibody, that there might be viral immune escape, meaning emergence of resistant variants. So it's not recommended. It's certainly understood why countries are doing this, but there's going potentially to be a price to pay down the road. I'm not going to bother you, but just to go through this, but other than just to say that these are some of the new vaccine versions that are coming out. One is this is a trial just doing it in children. That's not a new vaccine variant, but this is a cold chain requirement, trying to get around that by using lyophilized vaccine or giving the version 2 that has activity against 351. Just a couple more slides, just vaccine passports. It's a convergence of science and pragmatism. Proposed uses, I'm sure you're aware of, for both for movement restrictions within a country as well as international travel. Israel and France have them, mutual recognition of vaccine certificates discussed by Singapore and Malaysia. And there are already passes, one called Travel Pass, one called Common Pass, in use. There's some concerns associated with these. Does everybody recognize the efficacy of particular vaccines, security, and harmonizing standards? So just to be a bit of a naysayer, vaccines, how effective are they at preventing infection? That's a concern, how long the efficacy will last and when a booster will be needed. This has an impact on herd immunity. The uneven vaccine rollout has an impact on herd immunity, causing the R0 that Louisa mentioned. The variants can cause that, and as a consequence, change what the herd immunity threshold is. The duration of immunity, either after vaccination or infection, and vaccination might impact human behavior, which subsequently impacts infectivity. So that's a whirlwind tour of what was going on, and I will stop there and stop sharing my screen. All right.
Well done, David. I wonder if the three of us could have packed anything more into that hour, which turned out to be an hour and a quarter.
I could have not taken I could not have taken a breath. That might have helped and just spoken a little quicker. All right. Well, Dale, tell us, Dale, what you have for us.
Well, I can tell you two things. Next month, I'll be doing the show from Australia.
Oh, excellent.
I will have done my quarantine, and so that'll be interesting, going through the whole process. First trip since February in China last year. But to round out the show this month, I thought this actually takes quite a little time to find the best video, and I thought it's been St. Patrick's Day, and what more uplifting a way can you do than to have some Irish dancing? So I've got a nice COVID version of some Irish dancing for St. Patrick's Day.
So I want to thank Richard and Dale and Louisa for sharing their perspectives, and let you know that next month's episode will be on the 22nd when Dale's in Australia at the usual time. Do submit your questions and topics for us to consider through the chat box, which will stay open for another 10 minutes or so. Our pandemic song of the month is the powerful theme, You Gotta Be, which was originally released by the British singer Des'ree. It's an infectiously sunny tune about the affirmative powers of self-confidence and having the inner strength to weather these uncertain times. And it'll be followed by Dale's selected video. Until next month, stay safe, wear your mask, wash your hands, socially distance, and get vaccinated. Thank you for watching. Enjoy, and good night.
They pull my hair, they stole my comb. Well, that's all right till I go home. She is